We are the Center for Advancing Health Outcomes. Research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
Hi, welcome everybody. My name is Krishnan Ramanathan. Some of you look familiar. I'm a cardiologist here, and I've been asked to introduce Frank Scheuermeyer today. I've known Frank for a number of years. I won't tell you how long because that might give away how old we are. This is the first in the program of advancing healthcare or health work in progress seminars. So this is the first one. So you can imagine when the first one, it's usually very important. We're going to be talking about, or Frank is going to talk about the new developments in the emergency department chest pain research. Just to put it into perspective, chest pain is one of the most common presentations in the emergency department. We may see it up to 10 times or even more. But the chest pain is usually sometimes a harbinger of somebody having a myocardial infarction, which is irreversible damage to your heart muscle. And in Canada, every 5 minutes, a Canadian is having a heart attack. So it is very devastating, not just for the individual, but for the family and for the community involved. And Frank has been very involved in trying to advance the care or management of chest pain and early detection of myocardial infarction, and which is what he will be talking to us about. In his capacity, he works as a physician in the emergency department. He is the head of research, not just for the St. Paul's Emergency Department, but he's also the director of research for UBC Emergency Department. So he wears multiple hats, as you can see. Despite that, he's still able to publish in over 180 peer-reviewed publications, and he's a reviewer for more than 10 journals. So he's a very busy guy. But above all that, he is a great collaborator. You know, as I'm from the cardiology department, we have a great collaboration with Frank and the rest of the emergency department, and he's been the sort of the segue between our two departments to advance care of patients. So Frank, welcome. So you have the important task of being the first of the season for this year for the 2024-25. And I understand that your title is New Developments in Emergency Department Chest Pain Research, a BC Perspective.
Well, thank you so much for those warm words. I've obviously, it's always a team effort doing these things. And, there's obviously a number of people to thank here, and you'll notice a number of very familiar names here. This is a collaboration between multiple different services. This isn't just some lone emergency physician doing this. This depends on a lot of people at multiple different sites over many years doing this. Ultimately, St. Paul's Hospital Providence Healthcare works very well because there's not all that many barriers between departments. Some sites might have that, and some sites where I trained certainly had that. But sites, or the local site, works very, very well. I can just reach out to somebody and make a suggestion, or someone can make a suggestion to me, and there's a good chance it gets acted on. So just a number of people to introduce here, and this has been a project that's been ongoing for many years. So in no particular order except sort of time, Dr. Jim Christensen is the former UBC Department Head of Emergency Medicine, and you'll see his name crop up on a few papers. Dr. Grant Innes is the former Department Head at St. Paul's and Calgary. Dr. Douglas McKnight was the department head in VGH. Eric Grafstein is a former department head of St. Paul's Emergency Medicine. Dr. Kenneth Jin and Chris Thompson initially were cardiologists that initially helped Dr. Christensen and Innes out with the initial studies. Dr. Marla Keese was also very instrumental in this and still works very hard in working with our chest pain patients. Barbara Boychuk was an outstanding research nurse who I had the privilege of working with. Moving towards a more recent generation, not that these people aren't still involved, but working towards a more recent group of people that have now sort of almost taken over the pain initiative. Dr. Karen Humphreys is the professor emeritus of cardiology. Dr. Ramanath, you know about, a cardiologist who I've worked with for many, many years. Dr. Mattman works as the head of pathology, I believe. Is he the head? Pathology and lab medicine. Dr. Ken Kayla is a cardiologist whom I work with a lot with this as well. Jonathan Leipzig and Philip Blanky are diagnostic imagers who run an outstanding cardiac CT program. And then Annie Chu is a cardiologist who basically sees a lot of our chest pain patients and I coordinate with. Ross Duncan is a researcher who I coordinate with. And of course, Dr. Brian Gurnow is an outstanding emergency physician researcher as well. So this is a team effort. I sort of speak for the team and help to coordinate things, but many, many other people go into this. It cannot be just you yourself. I have no conflicts or disclosures of interest to report. The main goal, I want people to understand the role of overall care systems in chest pain management. It's not just a single physician making a decision or a single nurse making a decision. It's an entire care system that puts the physician and the patient in the position to be able to succeed and make the correct diagnosis with the least amount of resource use. Briefly, I'm going to discuss how things were. You can largely think of our chest pain initiatives as large quality improvement initiatives. I'm going to talk about what chest pain was like 20 years ago. I'll talk about the development of the St. Paul's chest pain pathway, which if you're a clinician, you've probably heard of. Then I'll talk about Jim Christensen's Vancouver chest pain rule. We'll talk about provincial implementation of the rule. And lastly, we'll talk about the status of chest pain management in 2024. So in 2004, that's 20 years ago, and I picked that for a certain time, this paper was among the most influential ever published here. This has 2,700 citations. As you can tell, it's from 2000, and it's obviously, not very recent, but it's still quoted endlessly. Misdiagnosis of acute cardiac ischemia in the emergency department. Basically, how often is an acute coronary syndrome missed? And this paper has been unbelievably influential. So that's a large study out of 10 hospitals in the eastern United States, of which 17% had acute myocardial infarction, and the majority had non-cardiac problems. The results are quite discouraging. 2% with a myocardial infarction were discharged home from the emergency department, and 2.3% with unstable angina, which is a precursor to myocardial infarction, were also discharged. So overall, you're looking at 1 out of 50 patients essentially with an acute coronary syndrome were misdiagnosed inappropriately in the emergency department and sent home. Now, a number of things come to light here. First of all, only about, at the time, 20% of patients with chest pain had a myocardial infarction. The rest of the people you could have pneumonia, you could have a fractured rib, you could have chest pain that we never really diagnose. There's also other lethal conditions such as a pulmonary embolus or an aortic dissection, both of which can be very difficult to diagnose and are quite rare, but you have to watch out for these things as well. So if you're an emergency physician or a cardiologist or an internist, or a family doctor, or anybody seeing a patient with chest pain, you have to ultimately worry about a whole bunch of diagnoses, but the most common one, and the one that commonly causes problems, is a misdiagnosis of cardiac ischemia. Now, this study, as influential as it's been, it's a New England Journal study with 2,700 references or citations, has a couple of problems. And number one, they didn't define myocardial infarction, they didn't define unstable angina, and they didn't define what mistakenly discharged meant. So fairly glaring mistakes that obviously call into question a little bit the results of this thing. So at the time, Dr. Jim Christensen, Grant Innes, Kenneth Jin, Chris Thompson, and Marla Keese decided to see if we could replicate this study in Canada. And a couple of years later, they came out with this study, Safety and Efficiency of Emergency Department Assessment of Chest Pain. This is in CMAJ in 2004. So the team defined missed acute coronary syndrome as a 30-day acute coronary syndrome, so myocardial infarction or unstable angina, in a patient who was discharged without any cardiology-specific follow-up. That means the emergency physician didn't even really consider the diagnosis. At the time, you might have said, well, it's just heartburn. it's just rib pain. It's just, pneumonia. And you didn't even think about a heart problem. So the results were actually even more discouraging. Nearly 2,000 patients, of whom 20% had some sort of an acute coronary syndrome. And we had 5% of patients discharged without a diagnosis of acute coronary syndrome and without plans for any kind of further investigation. So 1 out of 20 patients were essentially discharged home with a misdiagnosis, which is quite unacceptable. At the time, the consultation rate was 46%. So 46% of patients, nearly half of patients were consulted to cardiology. 37% of patients were formally admitted to hospital. And the length of stay, if you were going home, was still 8 hours. So just keep those numbers in the back of your mind, sort of. So what do you do about this? Well, you might think these physicians are really dumb, aren't they? These people are showing up with, patients are showing up with chest pain, and the physician says, oh, no, it's just heartburn. You can go home. But in fact, as you read through this case scenario here, and this is off the CMPA, which is the Canadian Medical Protective Association, which is essentially a group from practice insurance, although not quite. This is a case scenario of a patient who has a delayed diagnosis or a misdiagnosis of a myocardial infarction. And you can see it's not that simple. And in the emergency department, you grapple with things like major communication barriers. You grapple with things like no resources. You grapple with strange stories. You grapple with, tests aren't available. So it's never quite as simple as somebody clearly having a story of squeezing chest pressure radiating to their left arm or jaw that gets worse when they walk upstairs and better when they rest. It just doesn't happen that way. And here's a really typical story. A patient has a mild traumatic experience. It's uncomfortable. And the patient shows up in an emergency department that's really busy, says they have shoulder pain, and gets triaged to an area where shoulder pain gets treated. At St. Paul's or VGH, you'd be getting triaged to the treatment area, and you'd probably sit there for a while. And it might be a long time before someone does an ECG. This is completely possible that this happens. So the one sort of personal story I have is it actually happens surprisingly infrequently at our sites. The most personal story I have is one of my best friends about 7 years ago was at a site where a patient attended. She was in her 70s. Her family was able to translate for her that she'd been mildly nauseated for a day or so. Didn't seem like anything major. At the time, mild nausea, the patient looked well, had normal vital signs. The triage nurse actually ordered blood work for abdominal discomfort, which turned out to be normal. And the triage nurse actually started an intravenous and provided the patient with intravenous Gravol and sat the patient in a chair in a sort of a fast track type area. By the time my friend saw the patient felt completely better, and the family strongly advocated for the patient going home since they felt better. What was the point of staying, right? 3 days later, she reattended a different hospital and with, again, mild nausea and weakness, and someone happened to an EKG where there were signs of probably a heart attack having occurred a little bit earlier on. And when cardiology admitted her and did an echocardiogram, which is an ultrasound of the heart, they found that she probably had some heart damage. So this was essentially a missed myocardial infarction. But look at the things that were working against making the diagnosis. The patient had basically atypical symptoms, felt completely better. There were some communication barriers. And this is the things that do get missed. And it's actually kind of amazing that the misses are surprisingly obvious. So just in case you're thinking the physicians are, stupid or lazy or just can't do their jobs, it's never quite as simple as it seems. The patient ultimately ended up doing quite well. So this is, again, from the Canadian Medical Protective Association website here. And what are the most common patient conditions and criticism involving diagnostic errors? Fractures are common, but as you can see, ischemic heart disease is still a fairly common thing to miss. And there's lots of reasons, like we've said, for missing these things. The difference is a missed fracture, something, you might hurt for a while or have pain afterwards. Myocardial infarction, as Dr. Ramanathan said, you're probably left with permanent heart damage, and it's probably a bit more serious. So it's certainly something to watch. There haven't been any recent publications on lawsuits, and certainly nothing in Canada because all the payouts are generally confidential in Canada. This is from the United States paper a number of years ago, maybe 5 or 6 years ago. You're looking at about 200 cases of missed myocardial infarctions. And in the United States, they do keep large databases on these things. As you can tell, the payout can be quite large. $126 million seems like a little excessive. As you can tell from the distribution there, the average payout is probably a lot higher than the median payout. I assume a couple of really large payouts really skew this. But the bottom line is that it's a very litigious aspect of emergency medicine, is a missed myocardial infarction or unstable angina. So it's something we're taught never to miss. In the United States, things are a bit different than here. In the United States, generally speaking, 30 to 40% will get admitted directly to cardiology. Another 30 to 40% will be admitted to a chest pain unit, which is often in the emergency department. And often that's supervised by hospitalists or family physicians. Many patients, maybe not most, but at a lot of sites, the majority of patients will receive additional testing such as stress testing, echocardiograms, which is an ultrasound of the heart, and cardiac CT, which has become more important of a test recently. So generally speaking, this is obviously driven by other features. There is essentially a zero tolerance policy, so you're always going to get more tests in an environment like this. And there can also be financial reasons for admitting people to hospital under those circumstances. In Canada is more like Australia and New Zealand, in which case often the emergency physician makes the diagnosis most of the time. About 25, 30%, 40% of patients are consulted to cardiology, but the majority of patients end up going home the same day. So United States standards are quite different than here. And from a research point of view, it sometimes makes things a bit difficult to publish in United States journals just because the care environment is very, very different. So in response to this 5.3% miss rate, a number of cardiologists, emergency physicians, laboratory medicine specialists got together a long time ago and decided how to evaluate this. I'm including radiology now because they're now part of our chest pain pathway, but initially they were not. So laboratory medicine I should have included on there as well, and I'm sorry about that. So ultimately, what we'd like to do in the most simple possible terms, everybody tries to do this, but it's really how you implement the system that makes all the difference. So high-risk patients are obviously sent to cardiology. Now, how you define high risk is anybody's guess. Low to moderate risk patients are generally observed, and then very low risk patients, you're supposed to have a rapid discharge of these patients. A lot of your patients end up being very low risk, and if you keep tens or dozens of patients around for many hours, if you've been to an emergency department recently, there isn't a ton of space. Even 20 years ago, there wasn't a ton of space. There's certainly less now. So if you're keeping patients in hospital or in an emergency department, if there's nothing really wrong with them, that's not a great use of resources, because at some point somebody will come in that does need the resources. So you want to send these people home that are low risk, and you want to reassure them that nothing serious is going on. So ultimately, most chest pain pathways, and other hospitals have these things as well, right? You do what's called a sequential EKG. So an EKG is an electrocardiogram, a map of the electrical activity of the heart, and then you obtain a biomarker. 20 years ago, it might have been something called creatinine kinase. Now we're into third or fourth generation troponins, which are proteins that are released when the heart is damaged. So these are done at 0 hours and 2, 3, 6, 8, 10 hours sometimes. These tests are repeated to see if there's any kind of a change. If the testing is stable and the patient is pain-free, generally speaking, the patient is sent home. Now, I'm going to put a big, big asterisk on here, because this is really where issues can arise. A lot of patients will have no pain. They'll have had pain yesterday or in the morning, and then they show up and have no pain for hours, and their testing is all completely normal, but they may be sick. So who decides who gets what test? And this is where it becomes really, really to figure out what's going on. Now, at a lot of sites, you have to call a cardiologist, and the cardiologist will decide to see them in the office at some point, maybe 3 days from now, maybe 2 weeks from now, or maybe longer. Often you have to be on hold to wait for them, or you have to phone the cardiologist specifically, or your unit clerk has to write a paper referral. Then, referrals can get lost. Patients can decide not to attend, or something can happen in intervening time. There is St. Paul's doesn't quite do that. So what we have is a one-click, no barrier referral. In that case, on the computer system is one click and you're referred to the cardiologist. Often we print out an appointment immediately for that patient, what kind of follow-up testing you're supposed to get. There's rapid outpatient testing. So often, if you're ordering things, something like cardiac CT or stress tests, these tests are done within 24 to 48 hours, which is unreal. When I worked in Calgary, you might get to see a cardiologist within a week, and you certainly wouldn't be getting any of that kind of testing. Now, most critically, for our point of view, whoever interprets a thing like a stress test, for those of you who aren't familiar with a stress test is, you walk on a treadmill where we try and reproduce conditions of cardiac ischemia. We try and make a patient exert themselves so that they generally get, they might get chest pain, and then you keep an EKG on them and see if there's any EKG changes. What happens is the cardiologist actually interprets that test in real time and takes responsibility for the test, which is really unheard of. Generally speaking, in medicine, once you order a test, you're responsible for that test. The other thing is that a radiologist, if the radiologist is looking at our cardiac CT and says, "Oh boy, there's a blockage here in a critical area," the radiologist will actually take care of the test and make the appropriate decision for the patient, which is, again, really, really uncommon. And it speaks to the collaboration that we have between our various departments. So I'll explain a bit more how that works later on, but ultimately these things are what distinguish from trying to pick up the phone, call a cardiologist to make an appointment. Ultimately, it's a much lower barrier approach, which makes it easier for the patient and makes it easier for the physician to attend these tests and get the test results interpreted quickly. Ultimately, patients with high-risk testing are referred to the emergency department or right back to the emergency department. So if someone does an exercise stress test and develops crushing chest pain and has changes on their EKG that resemble a heart attack, that's obviously really serious. Such patients are then referred to the emergency department. On top of that, the cardiologist will almost always pick up the phone and call down to the emergency department saying, "Hey, look, this patient's coming. They were in your chest pain pathway. They were referred to us. This is much too high risk. They need to go back to the emergency department for a recheck." The same thing with cardiac CT. If a patient has a very high risk lesion, like let's say you've got a blockage at one of the main arteries, then the radiologist will phone down to the emergency department and say that a patient is going to be coming down and exactly what the problem is. And in most cases, the emergency physician will turn around and arrange for an immediate cardiology referral. And our cardiology team will often see the patient within, a very short period of time and make an appropriate disposition decision. This doesn't happen that often, but it's an important part that you're not being seen in an office, 30 minutes away from the hospital. You're in the hospital and just ferried down. If your testing is low risk, and let's say there's some diffuse disease, or you didn't quite achieve your target heart rate and a little bit of chest pain, but nothing really serious is going on. Or let's say you had what's called a MIBI, which is a nuclear medicine scan, which shows some evidence of heart ischemia. At that point, but you're not terribly sick. At that point, we have a number of options, and the cardiologist will often make a referral to another cardiology clinic called the Healthy Heart Clinic, or perhaps to a chest pain clinic. So these patients are seen by a cardiologist, but again, the emergency physician isn't dealing with that anymore. The cardiologists have kindly agreed to take responsibility. This is actually a really, really nuanced thing, and I'm really glossing over the kind of detail that goes into the actual individual decision-making about who goes up where. But for the purposes of this, it's probably the best thing to grasp is that the cardiologist or the radiologist will figure out a way to have that patient seen in a good time frame by a cardiologist. Again, these aren't your critically ill patients that need an angiogram or a stent right away. These are patients that do need some sort of follow-up and medication changes, but they might not need to be admitted to hospital. This is a really key part of the system, and it's kind of hidden for me as an emergency physician. And lastly, patients that have testing with essentially no risk, like a cardiac CT that's, got minimal or no disease, or an exercise stress test where the patient does perfectly well. Patients like that are deemed to have essentially minimal evidence of or no evidence of heart disease. Patients can be followed up with primary care. They do not need to be seen by other people, and they're essentially discharged from the chest pain pathway from a cardiac point of view. Hopefully I've explained that reasonably well. Whenever I submit this kind of stuff to American journals, they always kind of get they always get a little confused by this kind of stuff here. So here's what we published on it. And again, it's a few years ago. This was the initial evaluation. I was not actually around for the initial evaluation. I just inherited the data. kind of wrote it up with a bunch of team members. So 1,000 patients consecutively went through the system, and the 30-day acute coronary syndrome miss rate was 0%. So essentially, we've gone from a 5.3% miss rate to a 0% miss rate. So I think that's, from a quality improvement point of view, I think this is what you'd be looking for. Now, the other thing I would point out is a line below that. You can also tell that the majority of patients were diagnosed in the emergency department, but nearly 1 in 5 patients received the diagnosis during outpatient testing. So these are patients that would have had an outpatient stress test at the time, or now an outpatient cardiac CT, and they would have they would have had a positive stress test or a high-risk stress test, and would have had the diagnosis essentially made on that. It also goes to show you that a certain number of patients, you're never going to make the diagnosis in the emergency department, and you are actually relying on having this system that allows patients to go home and be essentially diagnosed as an outpatient, and then monitored safely. So after that, we introduced our outstanding cardiac CT team, and Dr. Jonathan Leipzig is a Tier 2 Canada Research Chair, and he's got an incredible publication record, and I believe he's the regional department head. I don't know if he gets any sleep, but he certainly manages to do it. And we've been able to introduce cardiac CT on an industrial level. In fact, we probably overuse the test now. And what cardiac CT allows us to do, rather than having people walk on a treadmill, which a lot of people kind of dislike doing for 12 minutes. What cardiac CT does, it's essentially you get a picture inside somebody's coronary arteries. And we decided to incorporate this into our system about 10 years ago, and 12 years ago. Time really flies when you're having fun. And we enrolled 500 consecutive patients early on. Basically, what we showed here is that this is a very safe test. Nobody had a major adverse coronary event before they got their cardiac CT. And this appears to be a safe thing to do as an outpatient. If you read the American journals, these things are generally done as an inpatient. You stay in the hospital. Let's say you show up at 6 o'clock at night, then you're staying till the morning until your test is interpreted. So often you're staying for 18 to 24 hours. With us at the time, you stayed for 6 hours, and now we're going to show it's a bit less. But it shows that cardiac CT can be incorporated into this kind of an evaluation pathway. So here's, then we compared cardiac CT to stress testing. Stress testing was always the gold standard. And there's a paper we published around the same time. So we had 521 consecutive patients with cardiac CT and 1,171 with stress test. So roughly similar proportions of patients ended up having an angiogram. Now, this is important because in United States literature, cardiac CT was seen as a major driver of having angiograms. And I think that's because the threshold for obtaining an angiogram is far lower in the States than it is here. Here, you have to have a pretty serious blockage, probably above 50%, maybe above 70% to get an angiogram. In the United States, the threshold for getting an invasive angiogram is a lot lower. You might need a lot less disease. So we were able to show that the proportion of patients getting an angiogram is roughly similar to the cardiac CT or a stress test. The number of people with an additional test, did they need another test on top of their first test, was 7% for cardiac CT and 27% for a stress test. The problem with stress tests is they're often not very conclusive, and sometimes you need another test to show whether illness is truly going on. So essentially, cardiac CT is a more definitive test as to whether there is any kind of a coronary artery blockage or not. And then when it comes to radiation exposure, that was a major concern with cardiac CT. It's 4.1 millisieverts. This was with the previous generation of scanner. It's less now. Obviously, with an X-ray stress test, there's no radiation. The trouble is, for 27% of people who do have an additional test, a lot of them got what's called a MIBI, a nuclear medicine scan, and that actually has quite a bit of radiation as well. So just because you're initially receiving a stress test is no guarantee that you're not going to get some radiation down the road. So ultimately, cardiac CT is at least seen as a reasonable alternative. It's a more definitive test, and it does not drive invasive angiography. So a few years ago, we made a change from troponin at 0 and 6 hours to 0 and 3 hours. So this is a different generation of troponin. Troponin, again, is a protein released when there's heart damage. And newer generations of troponins produce the newer generations of testing show this heart damage more quickly. Now, if you have to wait 6 hours for proteins to be released so that you can assess them after a heart problem, then you have to keep the patient around for 6 hours. But if you're able to, your test is good enough to pick damage up at 3 hours, that becomes a lot more preferable. So ultimately, could you send patients home earlier with if you changed your timing? Ultimately, the chest pain pathway initially had been 0 and 6 hours. You get a troponin at 0 hours along with an EKG, and then you repeat the test at 6 hours, and patients sit around for 6 or 7 hours waiting for these tests to get done. If you could change that to sitting around for 3 or 4 hours, I think patients would find that a lot better, and it frees up valuable emergency department resources. So a few years ago, in conjunction with all of our partners, we decided to take this on. The important people were also laboratory medicine, who I haven't mentioned that much, really were unbelievable assistance in streamlining this pathway. So let's talk about the Vancouver chest pain rule here. So again, I've talked about people getting stress tests afterwards and or cardiac CTs afterwards. Is there a way we can identify patients who don't even need that kind of testing? So the goal here is to provide a very sensitive rule that identifies your patients with cardiac issues and that allows for safe discharge, safely discharging chest pain patients that do not need any follow-up testing. If you could even cut down that a little bit, you're gonna, if you have 20 people that are supposed to get a exercise stress test and you can say only 10 people of them really need it, that really benefits the system quite a bit. It's also way better for the patient, obviously, if you don't have to go on a lot of additional testing. So the most common and popular rule is called the heart score. And essentially, it relies on the clinical prediction is actually unbelievably grotesque, but nonetheless, people do use it. Other percentage rules stratify the percentage chance of an acute coronary syndrome event. So what those rules do is say you have a 3% chance of having an acute coronary syndrome. You have an 8% chance of having acute coronary syndrome. Now, the disadvantage with that kind of thing is what do you do with that? If I was to tell you or a relative, you have a 5.4% chance of having acute coronary syndrome, what would you want done about that? Do you have to be admitted to hospital? Do you need to see a cardiologist? Do you need testing the next day? Should you stay for extra observation? It doesn't really tell you what to do. So what Jim Christensen and his team decided was to do a clinical prediction rule to try and figure out whether you need a test or not. So it's not, a sliding scale of here's your percentage chance of having an acute coronary syndrome. It's do you need this test or do you not need this test? And this is what the rule looked like. And yes, it's a little bit confusing. Ultimately, the rule was found to have a sensitivity of 98.5%. So 1.5% of patients would have been missed by this rule, and 32.5% of patients could be discharged home without any further testing. So essentially 1/3 of your patients right away you say you don't need any more testing, which is I think a great benefit to patients and the system. And a 98.5% sensitivity is probably acceptable. I think most physicians would say 1% miss rate is probably reasonable. The rule has been changed a little bit, which made it more difficult to publish because when you change from a development rule to a validation rule, changing your rule is not seen as a good thing. But we did change the rule a little bit here. And our rule turned out when we validated it, our sensitivity is actually improved. The rule only missed 1 out of 119 patients with an acute coronary syndrome, and the specificity wasn't quite as good. This is what generally happens with prediction rules, right? The development looks really good. The implementation or validation doesn't look quite as good. In our case, the sensitivity was a little bit better, and the specificity was a little bit worse, which is pretty much we'd predict, but still essentially one of every 4 patients you could send home without any further testing. The other rule is an Australian rule, and again, it's no surprise it's developed in Australia, which is a very similar rule to us, or similar environment to us. The no objective testing rule basically says if your age is less than 50, you have no prior acute coronary syndrome, and you have fewer than 3 cardiac risk factors, then you have, if you do nothing with these patients, you have a sensitivity of 99%, so it's only going to miss 1 out of 100 patients with a 32% specificity. So in essence, you could send home 32% of your patients without any further testing. Now, my only issue with this rule is that it's actually colleagues that developed this in Australia and New Zealand whom we've worked before. If your age is less than 50 and you have no prior acute coronary syndrome and you have the 3 cardiac risk factors, those 3 things together are kind of collinear. I mean, you're much less likely to have an acute coronary syndrome if you're less than age 50. So I'm not sure how independent these risk factors are. Ideally, they should be independent. But nonetheless, the rule actually does work quite well as well. But it's been tough to implement this in any kind of a setting. So what's made these rules a little more difficult? Well, the introduction of high sensitivity troponins has essentially, made diagnoses a little more quick so people don't use these rules that much. The other thing is the popularity of the heart score. Now, I've alluded to the heart score, and this was devised in the Netherlands in 2008. And this is what the heart score looks like. I don't want to develop too much time into this, but you will hear physicians use this. And so the development rule at 122 patients, which is not many at all, and it was not prospective, it was retrospective and non-consecutive patients. So essentially you're violating essentially every rule of clinical prediction rule development. And the outcomes for patients with a low heart score are a 2.5%. So still 2.5% of patients with a very low heart score will have bad the development rule. For the validation rule was also not prospective, and you had 880 patients and had about a 1% rate of having bad outcomes. And when they externally validated, it was prospective, a larger number of patients. So you're looking at about a 2%, 1.7 to 2% miss rate. So essentially, if your heart score is 0 to 3, generally speaking, you're deemed to be at very low risk. But here, 1.7% of patients with a heart score of 0 to 3 did in fact have an acute coronary syndrome within this follow-up time period. So you have to ask yourself whether this is safe or not. Now, I don't know whether it's clever marketing or good timing or whatever, but this is probably the most widely used score, certainly in the US, and lots of people in Canada will use this kind of scoring as well, even though it's really poorly kind of derived and doesn't have a lot of great numbers behind it, but nonetheless, it is very popular. And that's what's made implementation of other rules less popular. The trouble is once everyone agrees, sort of colloquially agrees on a standard, it becomes very difficult for something else to take its place, even if that might have more rigorous development or even better numbers. So again, the popularity depends on, maybe a cool acronym or once there's a certain amount of a buy-in, once a certain amount of number of people buy into this, maybe that's why it's worked better. But there's been no great explanation why a methodologically inferior rule has been so popular, even among other chest pain prediction rules. So one thing to look at now is how good is your rule. It's great if you have a good rule, but if nobody uses it, it's kind of useless, right? So we looked at provincial implementation of this rule, and this was again done under the direction of the former British Columbia Emergency Medicine Network, which is a network established a number of years ago by Jim Christensen to disseminate information across British Columbia emergency physicians. Obviously, if you work at different sites across the province, they're all on different electronic medical records, and they are all on different information platforms, and communication between groups sometimes isn't all that great. So not everyone uses the same stratification system to assess patients. So this is Emergency Care BC here, which is this, this is now funded by the Provincial Health Services Authority, and it's designed to, in essence, provide a tool for disseminating emergency knowledge and communication across the province. Probably a better slogan than I could have come up with there: sharing, supporting, and innovating to improve patient care. So the goal here is to promote the Vancouver chest pain rule across the province to assist in the safe early discharge of very low risk patients. Again, if everyone's using a different stratification system, some people might be sending a lot of patients home early. Some people might be keeping their patients around for a long time just to really make sure. But if there's no standard, then, whenever you have heterogeneous care, you probably have opportunities for the care to be less good in certain areas. And standardized care is usually always better care. The methods here are multimodal dissemination of the Vancouver rule to various British Columbia emergency departments. And what Jim Christensen did was fly around literally to a lot of sites across the province, talk about this, give presentations. This is still in the pre-Zoom days, and he would give what's called, at the time were called webinars, to the various department heads to see if this could be introduced. This was done on a regional level, especially with Northern Health. It was done on a local level. A lot of it depended on informal contacts as well, to try and promulgate the Vancouver rule to various British Columbia emergency departments. So in-person visits, webinars, lots of emails. We held some Ask Me Anythings. Each region had site champions. There were some very motivated local leaders that assisted with this as well. And it took really a couple of years to get all this done. Information dissemination and knowledge translation often take a very long period of time, and you need a lot of different ways to do this. And a lot of it, unfortunately, is informal things like gentle persuasion, contacts, convincing over a long period of time. It doesn't work instantaneously. Even if a major randomized trial comes out, people's behavior does not change instantaneously. So as this kind of thing has to be, it's got the weakest possible study design. It's a before-after design, which means it's vulnerable to a lot of unmeasured changes. The inclusion was based on triage codes of chest pain, cardiac features. Emergency departments have routine standardized triage codes. We used provincial data linkages to obtain the patient demographics, comorbidities, and 30-day outcomes. And this is published in the BC Medical Journal a couple months ago. Yay. Essentially just some, I could put the giant table up, but here's kind of the highlights here. Over 90,000 patients in the before group and the after group. The age of the patients was the same. The admission rate was essentially the same. And the 30-day patient outcomes were roughly the same. Essentially, the group of patients before and after is roughly the same. And this is from 2016 to 2020. Sorry, I should focus more on the admission rate. The admission rate goes from 23.7 to 22.5%, which is a 1.3% change. Now, that may not seem like all that much, but you multiply by 180,000 patients, you're saving probably thousands of admissions every year. And since each admission is 2 to 3 days and often can involve transfer to a larger hospital, you are actually saving, even with 1.3%, you're saving the system quite a bit of money and resources. And more importantly, you're getting a lot of patients home, thousands of patients home out of hospital much more quickly, which is what everyone would prefer to be. So ultimately, it's a before-after study, lots of vulnerability to unmeasured confounders. We don't know if the chest pain rule was used all the time. There are access with data quality. If you work with British Columbia data, it's not quite as good as Ontario data, so certain things like comorbidities could have been underreported. And obviously, we had no access to laboratory or EKG data. The patients still could have been different. They could have had higher troponins or different EKGs. But nonetheless, over an entire province, you're looking at thousands of patients not admitted to hospital safely, and you're looking at really probably tens of thousands of hospital bed days where patients didn't need to be formally admitted to hospital and spend time there, plus a lot of ambulance transfers from small sites to larger sites, which if you've worked in rural British Columbia, you end up doing quite a bit. So the important thing to know also is that immediate admission, if you have chest pain and you're admitted to hospital, you're going to stay 2 to 3 days in an urban setting. You're going to be admitted. In a non-urban setting, you can be admitted for quite a long time. If you're supposed to, even if you're in an area like Peace Arch Hospital, if you're supposed to go to Royal Columbian for your angiogram, you might wait a week or more to get that just because they can't get an ambulance. So people end up spending a lot of time in these hospitals. Given that there's been a large increase in patient volumes and in hospital admissions over the past 3 to 4 years, even knocking several thousand visits or several thousand admissions off your overall admissions is probably a pretty good thing from both a patient and a system point of view. So lastly, we'll talk about what the status of chest pain is in 2024. And it's a paper that actually just came out yesterday. So obviously we've known it's going to be published for a while. You'll notice a lot of people are on this that were accredited initially. And it's the safety and efficiency of basically going from a 0 and 6 hour troponin regimen to a 0 and 3 hour troponin regimen. So we looked at nearly 5,600 consecutive chest pain patients. There was no change in admission to hospital once we implemented a 0 and 3 hour rule instead of a 0 and 6 hour rule. Of the 433 patients with an acute coronary syndrome, one patient had a missed acute coronary syndrome. So that's 0.2%. So we've gone from 5.3% to 0.2%, which is kind of a big victory. The missed acute coronary syndrome actually was such a difficult case. I think it's actually very difficult to fault the physician who sent the patient home. The patient was unbelievably complex and may not even have had an acute coronary syndrome, but we did, according to the kind of rules we had to specify, we did count them. But nonetheless, that's pretty good. We also compared to nearly 12,000 patients with non-cardiac chest pain. Those patients had no change in length of stay or admission, and a few of them did have a coronary event. Obviously, someone who triages with non-cardiac chest pain can still have a heart attack, but essentially there was no change there at all. Now, how did resource use change for our patients from going from a 0 and 6 hour and a 0 hour and 3 hour troponin testing? Well, other sites have done this. So in Calgary, this is actually when I worked in Calgary a few years ago, they were implementing this, and the emergency department length of stay beforehand was 6.6 hours. After, and they went to an enormous amount of trouble to do this. Afterwards, their length of stay was 6.1 hours. So the change is essentially 30 minutes, which is good, but not great. Edmonton did this as well, and they went to, again, an enormous amount of difficulty to try and implement a different timing of troponin. Despite the fact you could get a troponin at 0 and 3 hours, even afterwards, the length of stay was still 6.2 hours, so a change of 18 minutes. Now, Sunnybrook, which is, probably, one of the seen as one of the best hospitals in Canada, a major trauma and referral center in Toronto, they went from a 9-hour length of stay beforehand, and I actually discussed it with all these I discussed all these findings with the authors of the papers that wrote this. They went from a 9-hour length of stay to an 8.2-hour length of stay, which is a 48-minute decrease, which is good. But again, even after they've gone to all this trouble, the patients are staying around for a really, really long time. Now, you might ask yourself, how did things go here? There's at St. Paul. So length of stay before is 7 hours. That's comparable. The length of stay after we go to a 0 and 3 hour measurement is 4 hours. So the change here is 3 hours. So this is kind of really unreported beforehand. Most other sites have gone to a tremendous amount of trouble in resource use to try and implement change and got a small change. I think we ended up with quite a large change. Now, why did that happen? Well, we have a really good relationship with everybody. We have an existing relationship with everybody. And, we talk to, as a team, and I'm including our cardiologists, our diagnostic imagers, our laboratory medicine specialists, and our IT people here as a team. Ultimately, what we've done is we've had the program for a long time, and making small changes becomes a little bit easier. It becomes easier as the group already knows it works. So making changes has a lot greater buy-in. And the thing is, we meet all the time for any sort of quality improvement pathway. You can't just say, we're going to set up this pathway and then walk away from it. Ultimately, it's like a garden. It needs to be tended all the time. And as cardiologists and emergency physicians and diagnostic imagers and laboratory medicine specialists, we do actually meet regularly to talk about this, to try and make things better. So we've had lots of experience here as well. The other thing is that our information technology works quite well. We moved from what's called Sunrise Clinical Manager to Cerner, and which is a big, big information change. If you work clinically, obviously you work probably at St. Paul's, you work with an electronic medical record. Not all these sites work with electronic medical records. Now, electronic medical records get a bad reputation because it's can be a lot of hard work, and people, they can be very time consuming and resource consuming, but they can also be, a really good force for change. In this case, for example, we actually pre-print the timing of troponin. So there's not a lot of thinking, should I do it 0 hours and 6 hours or 0 and 3? It's just presented to you as 0 and 3. So you actually have to use more clicks to get out of the pathway. And lastly, it's also the communication we have. We communicate regularly with all of our clinicians, not just the people designing the pathway, but we communicate regularly with all of our clinicians and solicit their feedback to try and make things better. So a large part of it depends on communication, teamwork, implementation, and willingness to listen to feedback. Overall, I'm just going to quickly wrap up here and describe the change from 2004 to 2024. At St. Paul's, our emergency department volume has gone from 45,000 to 105,000, which is a massive change considering that our bed number, footprint, number of nurses hasn't really changed all that much. The missed acute coronary syndrome rate has gone from 5.2% to 0.2%, which is a 5% decline, but it's actually probably a much larger decline. It's probably a 25-fold decline, which is, I think reasonably good. And lastly, the length of stay has dropped from 7.5 hours in 2004 to 4 hours, which is nearly a 50% decrease. So ultimately, when you have a clinical intervention or a quality improvement system where your resource use, like your length of stay, drops by half and your safety improves essentially 25-fold, that's a pretty dominant strategy. And that's worked out very well. And I think it's a testament to everyone involved in this that you need a strong team. You need a team that's willing to communicate, a team that's willing to integrate feedback to create something like this. Is there any more here? Yeah. And this is why it's worked. Multidisciplinary collaboration, willingness to listen to feedback, and very low barrier follow-up. I don't have to sit on the phone waiting half an hour for a cardiologist to call me back. It's a one-click referral. And lastly, if a patient needs to get sent back to the emergency department, it's not a tremendously laborious process either. So ultimately, this is almost rather than saying I'm a cardiologist, I'm an emergency physician, I'm a radiologist. Ultimately, we just think we're part of a team taking care of the patient. This kind of approach puts patients first, and it's been quite successful. Now, there's a couple of aspirations and future directions we'd like to do. Number one, clinical aspirations include decreasing our length of stay. We're actually moved to a 0 and 2 hour troponins now, finally, instead of 0 and 3. So hopefully that'll knock off another hour. We'd love to decrease our consultations for low-risk patients. Our cardiologists are very kind to see a lot of patients that probably they do not need to see simply because there's an aspect that worries an emergency physician, and we end up referring to a cardiologist. We can probably cut that down a bit. And we'd like to decrease our follow-ups for low-risk patients as well. They don't all need cardiac CTs. They don't all need stress testing. A lot of them can just go home, and we'd like to cut that down as well. On a system point of view, it'd be great if we had regional pathways. Right now, the care you get at other sites is still a little bit different. That doesn't mean it's not good. It's just different. And again, when you have standardized care, the care is better overall. So you could look at regional pathways. A patient that goes to Richmond should have similar care to what they get at St. Paul's, ideally. That doesn't mean we can't learn from other sites as well, but it just shows that the care is a bit different at each site. You could use cardiac CT as a gateway to angiography, for example. So if a patient's hospitalized at Richmond and the cardiologist there feels they need an angiogram, they're probably going to get an angiogram. Could you use cardiac CT to see if that patient really needed an angiogram or not? And lastly, and possibly most importantly, we'd love to get enhanced data for easier evaluation. Right now, getting your hands on data, especially provincially, can still be really difficult. If you try to get provincial data, it can take time, money, patience, and the data may not be accessible in a form you can readily use. So it'd be great if we get enhanced data for easier evaluation of these kind of projects. But these are all long-term aspirations that will take a long time to get better. It took 20 years to get from 5.2% miss rate to what we have now. It may take a while to get to these kind of things as well. You just have to be patient, keep your team around you, and keep communicating and keeping the patient first. So what we talked about today is what CHESPAIN used to be like, the improvements we've made, provincial implementation and knowledge translation, and lastly, what the state of CHESPAIN is nowadays.